So Dr. Khalifa, he is MBBS, MRCP, FRC path, CCT Immunology, is a consultant immunologist at the Salford Royal NHS Foundation Trust. He has many qualifications, including CCT in Immunology, Advanced Life Support, and membership of the Royal College of Physicians, along with many others. He also has many awards, such as winner of the Best Pitch Prize at Translation Manchester. He is going to give us a talk about diagnostic and management challenges in food allergy. So we'll proceed with that.
Hi, thank you for the kind introduction. Do you hear me well?
Yes, doctor.
Okay, thank you ever so much. Well, thank you for the kind introduction. It's a great pleasure and honor to join you at the first Emirates Allergy and Clinical Immunology Conference. What I'm trying to do in the next 20 minutes or so, I would like to examine the global burden of food allergy and reflect upon the advances in allergy diagnostics, also to elaborate on the risk stratifications with regards to food allergy management, prevention strategies. I also would like to share with you some of our experience here at Manchester with regards to cofactors and food allergy, and finally to highlight the future direction of food allergy management towards precision medicine. The global burden of food allergy can be approached at 3 different levels. Upon individual level, which that can result in huge impact on their mental health and well-being as a result of restriction in various activities and particularly children and young adults. When it comes to the healthcare burden, this may include severe reaction and anaphylaxis management, healthcare utilization, and all the comorbidities and mortalities that may follow. From the economic perspective, there are the direct and indirect medical costs. And I find it quite interesting. This is a publication from STK from Europe here, and that's just to reflect the spectrum of most frequent triggers of food-induced anaphylaxis in adults and children. And peanut is always stand at the top. So orange for children and blue for adults. And here you can see peanut is kind of the most common one in children, as we always expect. What exciting is wheat has been the top one here in Europe from this publication, followed by crustaceans, which is quite interesting. Now, the challenges in food diagnostic include, starting from the history, you can get up to 85% accuracy from the history. Then to further increase the sensitivity and the specificity of our diagnostic approach, we follow the skin allergy testing by the component resolved diagnostic, which will allow us to risk to stratify our patients in order to undertake a graded oral challenge safely if indicated. I try to usually kind of speak to my trainees and doctors and colleagues about skin allergy testing is the cornerstone of our investigation. And I believe there will be a workshop this morning about skin prick testing and allergy skin prick to prick testing as well. So it will be useful to attend that. With regards to allergen component resolved diagnostic, this is the best methodology ever, I can say, with regards to food allergy diagnosis, which has improved our ability to identify a specific clinical phenotype and risk to stratify our patient. So the risk of systemic reaction is higher towards storage proteins and almost none exist when it comes to the carbohydrate determinant. Then the question will come to sensitization of profilins, PR10, and LTP. So profilins are usually asymptomatic, and these proteins are abundant in nature. Some patients may have a oral allergy syndrome or pollen food syndrome. When it comes to PR10 or pathogenesis-related 10 protein, these are a labile protein as well to heat and digestion, although they are the main cause of pollen food syndrome. But what will happen, these patients may actually present with systemic symptoms, and I will share with you some examples and why some of these patients may present with systemic symptoms. LTP or lipid transfer protein, these are the most dangerous group of proteins. They are stable to heat and digestion, but also they associate with local and systemic symptoms. And most of you are aware, those patients with sensitivity to LTP, they can develop severe anaphylaxis in association with cofactors. And I'm going to explain some of the examples in a few minutes. So the hierarchy of plant food allergens demonstrate the level of identity of sequence across each group. So you've taken PR10, for example, MALD1 from apple, which is also, we call them BET-V1 analogs. So BET-V1 is a major allergen of birch pollens. It presents in many different edible plants. And it was first described in 1990s when people start talking about PR10 and BET-V1 analogs, but then the description carried on. Most of the patients with this PR10 or BET-V1 analog, as you know, they will rarely have systemic symptoms, but we'll have always to discuss about cofactors, which I'm going to show you in a few minutes. So by now, you would agree with me there are few sources of risk and challenges with regards to food allergy diagnosis and management. If we divide them into diagnostic risk and management risk, in order to reduce the risk when performing food allergy, for example, we should not only be careful in selecting which patient to undergo the graded oral challenge, but also to assess the other cofactors, which may increase the risk of reactions during the challenge, which is quite important. When it comes to the management, with regards to, in addition to the food allergy action plans and avoidance strategy and all that, then we need to pay a particular attention to nutrition counseling, to patient education, and also supporting children at school and addressing the unmet needs. So if we've taken the pollen food allergy syndrome, for example, you can see here two clusters. You've got the profiling clusters and the BET-V1 clusters. This is quite important because it's all about how to explain to the patient in a simple way without frightening the patient with regards to future risk of anaphylaxis. And a classical example I have here in Manchester, this patient who avoided eating any fruits and vegetables for 2 years and developed, this is extremely rare presentation in this part of the world, because he wasn't eating any fresh vegetables or fruits. He developed vitamin C deficiency. And after 4 weeks of treatment, he kindly shared his photo and agreed to share it with you in this conference. He kind of showed remarkable improvement, but the whole communication with the patient is a main key of management and assessing the risk stratification. So let's discuss a little bit about pollen food syndrome or PFS. More severe symptoms such as anaphylaxis are considered to be very rare, generally speaking. So in previous publications, the risk was around 1.7% of having actual systemic symptoms because of pollen food syndrome. But from this publication, following that, many recent data suggest that the actual risk is quite higher than that. So from this publication from the Korean group, they kind of examined more than 1,000 cases of anaphylaxis in different Korean hospitals for both children and adults. And they described that anaphylaxis has been reported in around 19% of children, and up to 12% in adult. And the same from Japan, recent publication as well, up to 10% of patients with pollen food syndrome, they can develop anaphylaxis with exposure to fruits and vegetables. There's a lot of certain foods or vegetables or triggers has been associated with such systemic presentation. There's a lot of work on atopic dermatitis in association with pollen food syndrome is a risk factor for developing systemic symptoms. So there's a lot of work on this, and recently there is currently a work within the British Society in Allergy and Clinical Immunology for writing a proper guideline and policy how to address all these cofactors. And these cofactors can be related to dietary cofactors or other cofactors. So for example, there are a few case reports with regards to exercise and fasting as a cofactor to develop anaphylaxis in exposure to pollen food syndrome component. Also atmospheric pollution, there has been a lot of work recently on pollution and pollen levels, and this can be linked to many reports of anaphylaxis. Gastric acid suppressions and all the operations has been recently introduced with regards to reducing acid in the stomach, and this has resulted in subsequently increased risk of anaphylaxis. And basically the profilins and the PR10 proteins just can make their way to the intestine and the blood and change, which can result in systemic anaphylaxis. And finally, lots of cofactors with regards to fruits and smoothies and nut milks, which is unusual for obviously product, and superfoods, which has led to large quantity of allergen exposure, and thus resulted in anaphylaxis. When you come to the lipid transfer protein, there's a lot of work as well on this across the world, obviously. From the UK, there's a report from Skypala and others with regards to which actual foods that can result in anaphylaxis. And tree has stood up in UK. In other European countries, beet has been the top, but that's keep changing. This is kind of an old publication by now. Cannabis exposure has been the most recent kind of risk described as a cause of LTP. When we come to the management challenges, the main management challenge for the patient on day-to-day practice is food labeling. And there's a lot of misconception with regards to this. So for example, risk of contamination can be stratified in the PAL, which is a precautionary allergen labeling terminology. But in fact, when you come to the practical application of this, a lot of PAL's terminology on food label cannot be used as a stratifying risk, because a lot of company uses as a precautionary label rather than a true allergy. The same apply for once a patient, for example, tolerate a particular food with a particular PAL terminology or precautionary allergen label terminology. It doesn't mean they're always safe to eat that particular food, because there might be a batch to batch differences in level of contamination and so on. The list of allergen labeling used by companies is quite different from what the real actual component being used. And we see the risk in restaurant, for example. There's a lot of report on this, and the food allergic reactions actually being reported in restaurant are perhaps very common, but third of these patients may actually require adrenaline autoinjector or epinephrine. And a lot of these reports make it to the media about particular restaurants when the patient develop anaphylaxis. Obviously, we have lots of cases in the UK you might heard recently in the news. So the problem is, how do we deal with such a problem? And the worrying fact that over half of these reported allergen reactions occurred despite reporting these food allergy to the restaurant staff. So the issue here is food allergy labeling legislation, I think, for restaurant does vary significantly between countries. and between region. And it's definitely, I think, worth establishing such a working group, perhaps with this society to address all the local issues and facilitate communication and also improve legislation with regards to food allergy. When it comes to school, this is a real challenge. There are many published evidence, approaches, policies, and strategies to try to minimize the risk of food allergen reactions at a school with variable outcomes. For example, lots of work being published about peanut-free school. However, results reveal that these schools are not really less likely to have a student require epinephrine or adrenaline autoinjector for their reaction. However, peanut-free tables showed significant decrease in such requirement. So school in children, apart from food allergy, just reaction risk, they have got lots of other risks, which sometimes will be difficult to address, such as bullying and building self-confidence. So that's, again, a whole rank of risk associated with a label of food allergy. If we want to address all the potential factors that may influence reaction severity, this can be approached at various levels. So for example, when it comes to the allergen properties, this, as we discussed earlier, whether it is a PR10 or profilins, LTB, or storage protein, this is quite essential. Then when it comes to the behavior factors, particularly children and young adults, again, these are the risk group which we have to address very cautiously. Cofactors such as medication, exercise, as well as host factors such as hormonal influences and various comorbidities, all these need to be addressed in a particular situation and should be addressed individually. And when it comes to cofactor, I think this is the most important challenge we face on daily basis when we treat our patient. Most of you are aware about TRACE study, which is one of the big multi-center randomized control crossover study that has confirmed the effect of exercise and sleep deprivation in significantly reducing the risk of peanut reaction and reducing the threshold for developing this reaction, but also increasing the risk of developing severe reaction. And that's one of the main studies, as you all aware, published in 2019, but there's a lot of other studies addressing exactly this concept of cofactor and how can we deal with such cofactor. In Manchester here, we try to put some label to all these food allergies and put some sort of a name for it. So we use this food cofactor anaphylaxis allergy syndrome as FCAS as a terminology for all the sensitivities to PR10 and LTP and omega-5 gonadin, and for all these patients presented with systemic symptoms and cofactor. And this is just kind of a screenshot of around 200 patients that's been presented recently of all the variable kind of presentation of systemic symptoms. You can see here lots of them present with exercise-induced or food-dependent exercise-induced urticaria more than actual anaphylaxis. And that's kind of what was the main presenting symptoms of their allergen. We can see others has presented with anaphylaxis or reported anaphylaxis, not necessarily a true anaphylaxis, but has been documented in the hospital, and others has presented with localized mouth symptoms. So try to kind of put them all together as all the food-dependent exercise-induced anaphylaxis, the wheat-dependent exercise-induced anaphylaxis, or the pollen food syndrome enhanced by cofactor and systemic symptoms, or the LTP syndromes and systemic symptoms with other cofactor in all-in-one terminology as FCAS. We used to hear locally, but obviously every region has been naming different ones, different syndromes for these conditions. And I think will be useful to actually address this cofactor in a very personalized way. So I think we have a genuine case here to work towards precision medicine and how to describe all these different allergens from LTP to storage protein back to PR10 and profiles, and how to link allergotype and phenotype kind of approach, and to address all the challenges we've discussed in order to mitigate the risk and improve the quality of life of our patient. So in conclusion, I think despite all the advances we have in diagnosis, management, prevention, and intervention, the burden of food allergy diagnosis upon individuals and families is substantial, minimizing the risk in daily activities and also in the graded oral food challenges and therapeutic approaches is critical for patient-centered food allergy management. Developing personalized food allergy has the potential to significantly, I think, improve the lives of food allergic individuals, their family, and have that allergotype phenotype precision medicine approach. Lots of patients and people to acknowledge, first society to acknowledge for all the work they're doing with regards to challenges in diagnosing and management policies,